Hello friends, let us now discuss the anatomy of paranasal sinuses. So in the previous topic, we have seen the anatomy of nasal cavity. Now we'll look at the paranasal sinuses. So by the definition, as I have taught you earlier, that these paranasal sinuses are around the nasal cavity. So that is why they are known as paranasal. Now we have already discussed basic anatomy in the starting of this nose topic. Let us go ahead and discuss more about these paranasal sinuses. Okay, so first thing over here, what we will do is we'll study a cross section of the nose and the paranasal sinuses. All right, so you see this is a coronal cross section. So what is this? This is a coronal cross section. So what do we see over here? You see a coronal cross section has been taken like this, right? So this is the coronal plane. We have cut to the nose and the sinuses, and what we can see right in the center, we have the nasal septum. Okay, so you can see that this is the nasal septum, and it is dividing the nose into two nasal cavities, right and left nasal cavity, as we discussed earlier. Okay, what else can you see over here? You can see the inferior turbinate. On both the sides in the nasal cavity, you can see the lowermost turbinate, that is the inferior turbinate. Now because that's the inferior turbinate, so you see this is the inferior meatus on both the sides, the space on the lateral wall. So you see this whole space over here, this is the lateral wall. All right, so you see this is the lateral wall. This is the lateral wall, and we have over here the inferior meatus over here. This also is the lateral wall, and we have the inferior meatus over here, right? Okay, let's see what else do we have. We can see over here the middle turbinate, right? So you can identify the middle turbinate. So this is the middle turbinate of the left nasal cavity, and this is the middle turbinate of the right nasal cavity. So if that's the middle turbinate, you can see the middle meatus also. All right, so you see this place which I am shading, this is the middle meatus on the left side, and this over here will be the middle meatus on the right side. Okay, so this structure we have seen. Now what lies lateral to the lateral wall? So we have seen the lateral wall. What is there lateral to lateral wall? You can see over here that there is a big space over here. Okay, big air cavity over here, big air cell, that is your maxillary antrum. So we have discussed the maxillary antrum earlier. We know about the maxillary antrum, the maxillary sinus. It's a very big cell, so it is known as maxillary antrum. We also call it as antrum of Highmore. Remember, we have talked about this, that this is the largest paranasal sinus. The volume is 15 ml, adult volume is 15 ml. It reaches adult size by 15 to 18 years. This is the first to develop. So we have discussed all that earlier. I'm not going to repeat that. We're going to study further about it. So let's see more about it. Now, in the previous topic, I told you that the maxillary sinus, it drains in the middle meatus. So you see over here that we have the maxillary sinus, the maxillary antrum, and it is draining over here into the middle meatus, right? So you can clearly make out that this is draining into the middle meatus. Now what lies above the maxillary antrum? You see what lies above the maxillary antrum. So we know that this place is the maxillary antrum. What will lie above the maxillary antrum? Above the maxillary antrum, we have the orbit. All right, and what is there above the orbit? Above the orbit, we have the frontal sinus. Okay, now thing to remember, once again I'll remind you that the medial wall of the orbit, remember the medial wall of the orbit, this wall over here is formed by the ethmoid bone. So remember, this wall over here, it is formed by the ethmoid bone. Okay, which part? The orbital plate of the ethmoid bone, which we also named as lamina papyracea. Okay, so this, remember, it was papery thin. This was the thinnest wall of the orbit, so we named it as lamina papyracea. All right, now where does the frontal sinus drains? You see, where is the frontal sinus draining? So once again, you can see that the frontal sinus is also draining into the middle meatus, right? So you can see the frontal sinus is draining in the middle meatus. Now, other than these two sinuses, if you notice, I have drawn one cell over here. So I'm putting a star mark in the cell. I've drawn one air cell over here, and this air cell I have drawn to represent the ethmoidal air cells. Yes, ethmoidal air cells are multiple air cells, okay, but over here right now I have drawn only one air cell. You know why? So as to make this diagram simple and easy for you to understand. If I have drawn multiple air cells, it will be confusing. So for the beginning, I have drawn only one air cell, and you see this cell is known as bulla ethmoidalis. This is the most consistent air cell of ethmoids. Most consistent air cell of ethmoid, bulla ethmoidalis. And you can see that this bulla ethmoidalis is also draining into the middle meatus. Right? So this is also draining into the middle meatus. So this air cell is belonging to which ethmoids? It belongs to the anterior ethmoids. Alright, so the bulla ethmoidalis also belongs to anterior ethmoids. So this is a part of anterior ethmoids. Now we can see the three sinuses opening. Maxillary antrum, we can see the frontal sinus, we can see the bulla ethmoidalis, that means the anterior ethmoids. All these three sinuses, you can see clearly that they are draining into middle meatus. Okay, so what do we call this area in the middle meatus where all the three sinuses are draining? We call it as osteomeatal complex. Okay, so remember, we call this as OMC, osteomeatal complex. Right? Okay, so I hope you have all understood this much. All right, let's go further ahead. Let's look once again back at the maxillary antrum. So when we look at the maxillary antrum, what do we see? We see that this maxillary antrum is draining like this into the middle meatus. Okay. Now, if you notice over here, it is draining into the middle meatus. There is a flap-like structure over here. If you notice, there is a flap-like structure over here. Okay. Now, this flap-like structure is known as uncinate process. What is this known as? This is known as uncinate process. Right? Okay. So, it's there on both the sides. Both the sides I have highlighted it that this flap-like structure is known as uncinate process. Now, the first question is, uncinate process is a part of which bone? It's a bony structure, okay, and this uncinate process, please remember that this is a part of ethmoid bone. All right, although it looks like it is coming up from the inferior turbinate, but remember it is a part of ethmoid bone. All right, now let's say this uncinate process was not present. Let's say this uncinate process was absent. Now what will happen? Suppose I say that there was no uncinate process. What will happen? Okay, so let me do one thing. Let me remove the uncinate process. So what I'm going to do is I'm going to remove this uncinate process completely from here. Okay, so as you can see, I have removed the uncinate process. I've erased it. Now what happens? So when I erase the uncinate process, you see that now the maxillary sinus drainage has become a big wide drainage. Okay, it's a wide drainage, and the drainage pathway has now become very small. You see, the drainage pathway has become very small, and it's a wide drainage pathway. So small means the lengthwise the drainage pathway is small, the widthwise the drainage pathway is more. Okay, right? But because we have this uncinate process, so what happens now? You know, the drainage pathway, it becomes longer. You see, this drainage pathway, it becomes longer and it becomes narrower. You see, this drainage pathway is now becoming longer and it becomes narrower. So this long and narrow drainage pathway of the maxillary sinus, this is known as infundibulum. Okay, so what do we call this? We call this ethmoidal infundibulum. Right? Now, why do we call it as ethmoidal infundibulum? You see, this is the drainage pathway of maxillary sinus. But where is this pathway situated? It is situated between the uncinate process. You see, on one side we have the uncinate process, that's a part of ethmoid bone. On the other side, you can notice we have bulla ethmoidalis, that is also a part of ethmoid bone. On the third side, we have over here the lamina peperacea. Remember, we talked about the lamina peperacea just now, and that is also a part of ethmoid bone. So this drainage pathway is drainage pathway for maxillary sinus. Okay, but this drainage pathway is in the, yes, it is in the ethmoid bone. So it is known as ethmoidal infundibulum. Okay, so therefore you see the maxillary sinus ostium. Somebody asks you, where is the maxillary sinus ostium? So remember that the maxillary sinus ostium is over here. This ostium is over here at the lower end of the ethmoidal infundibulum. We have the maxillary sinus ostium. Okay, so from here the drain, the path, this whole secretions, they have gone into a drainage pathway, that is the ethmoidal infundibulum, and the ethmoidal infundibulum is in the ethmoid. It's a long and narrow drainage pathway, and it gives out everything into the middle meatus. Okay, now this ethmoidal infundibulum, we have seen it lies between the uncinate process, bulla ethmoidalis, and the lamina peperacea. Okay, so I always compare it to a hall. Suppose there is a big hall. Now this big hall is the antrum. All right, so this big hall is the antrum. Now this is the end point. This is the door of the antrum. Now from here you enter into the infundibulum. Okay, so this is the antrum, and you want to go out of this hall, you go in the lobby. This is the infundibulum. Okay, so this over here, you see, this over here is the place where the antrum ends. Right, so now we have a long and narrow pathway. This long and narrow pathway is known as infundibulum. Now where it ends, at this place there is a plane. Okay, so where this infundibulum ends, there is a plane. There is the last point. Okay, so remember, the antrum is a three-dimensional space, the infundibulum is also a three-dimensional space, and at the end we have a two-dimensional plane. This two-dimensional plane over here, this is known as hiatus semilunaris. So what do we call it? We call it as hiatus semilunaris. So two-dimensional plane between uncinate process and bulla ethmoidalis, that is known as hiatus semilunaris. So once again, you see, let's say we have the antrum. Antrum is a big hall. You want to go out of the hall, you cannot directly go out because there is a long narrow pathway. You have to travel through that. That will be known as the ethmoidal infundibulum. Now when the ethmoidal infundibulum ends, there is a door. So when you open the door, finally you can go out. That door is a plane. It's not a space, it's a plane, and that plane is known as hiatus semilunaris. Okay, so similarly over here we have the hiatus semilunaris. Right? Okay, now we have seen these cells. We have seen the maxillary sinus, we have seen the frontal sinus, we have seen the bulla ethmoidalis, that's a part of the anterior ethmoids. Now let's do one thing, let's study some more cells in the ethmoidal system. Okay, so we can have cells in the ethmoids which are above the bulla ethmoidalis or which are below the bulla ethmoidalis. Okay, so you can see over here I have drawn two more cells. One cell above the bulla, we will call this cell as suprabullar cell. Okay, so this cell is known as suprabullar cell. Now there can be a cell below the bulla that I have also drawn. Now this cell is not just below the bulla. If you see, this cell is also below the orbit. So you can see the orbit over here. So this cell is also below the orbit. Therefore, we will name this cell as infraorbital cell, also known as Heller cell. Okay, so this cell is known as infraorbital cell or Heller cell. Now see what happens to ethmoidal infundibulum. If there is a Heller cell present, what will happen to the ethmoidal infundibulum? You see, this ethmoidal infundibulum has become even longer and narrower. So you can see that the ethmoidal infundibulum, the drainage pathway, is long and narrow. So if we have a very, very big Heller cell, it can actually block the maxillary sinus ostium and patient can have maxillary sinusitis because of this blockage. Okay, so the anatomy will also affect how much prone a patient is to the sinusitis. Right, so that was the Heller cell or the infraorbital cells. Now we have seen the cells. You see, let me say that this is the bulla ethmoidalis, and I put my hand above it, so that is the suprabullar cell. If I put my hand below it, this is the infraorbital cell or Heller cell. So now we have seen in one plane. Now there can be a cell which is anterior to the bulla. Okay, so we can have a cell anterior to the bulla. So let me draw over here. There is a cell one that I have drawn anterior to bulla. We call this cell as Agar-Nezae cell. So this cell is known as Agar-Nezae cell, and remember, this is the anterior most cell of ethmoids. Okay, so Agar-Nezae cell, very important question. This is the anterior most cell of ethmoids. Okay, anything more important about Agar-Nezae cell other than just being the anterior most cell? The Agar-Nezae cell is in close approximation to the lacrimal bone. So remember, just anterior to the ethmoid, we have the lacrimal bone. Okay, so you see the Agar-Nezae cell is in close approximation to which bone? Lacrimal bone. Sometimes the nematization may extend into the lacrimal bone itself. Okay, and we know on the lateral aspect of the lacrimal bone, we have the lacrimal sac also. Okay, so we have the lacrimal sac lateral to the lacrimal bone. That means Agar-Nezae cell is in close proximity to lacrimal sac also. Okay, so which surgery do we do on the lacrimal sac? On the lacrimal sac, we do the surgery that is known as DCR, dacrocystorhinostomy. We studied about it in the last topic. Now, I told you at that time we can do an endoscopic DCR. So instead of giving an incision on the skin, on the face, okay, so we can do a endoscopic DCR. So when we do an endoscopic DCR, we go inside and we identify the Agar-Nezae cell. So which cell do we identify? We identify the Agar-Nezae cell, and then we break this cell, we identify the lacrimal sac, we open up the lacrimal sac, and we make an opening in the middle meatus. Right? Okay, so that is how we do the endoscopic DCR surgery. Now, there can be cells above the Agar-Nezae. Okay, now for that you have to understand the frontal sinus anatomy. Okay, you see the frontal sinus, I showed you in this diagram, the frontal sinus is coming from the side. It is above the orbit, but you see that this sinus is superficial. It is very much anterior. Okay, this sinus is anterior. So not only it is coming from the side, but it is also coming from the front. Okay, so this sinus is coming from the front like this. All right, now we have a bulla ethmoidalis over here. Okay, we have a bulla ethmoidalis. Above the bulla ethmoidalis, we had the, yes, suprabullar cell. Below the bulla, we had the, very good, come on, we had the Heller cell, infraorbital cell. Okay, now I told you that anterior to this bulla over here, we can have another cell. So we have the bulla, anterior to bulla, we have another cell. That cell is known as agar nasal cell. Okay, so remember bulla, suprabullar, infraorbital, anterior to bulla, we have the, yes, we have the agar nasal cell. This is the anterior most cell of ethmoids. Okay, so we have the agar nasal cell. Now, how is the frontal sinus coming? The frontal sinus is draining like this. Okay, the frontal sinus is draining like this, and you see this is the bulla ethmoidalis. It is coming like this over here. Okay, so it is coming and draining over here like this. Now, suppose we have a agar nasal cell. All right, if there is a cell above the agar nasal, so I'm saying if there is a cell above the agar nasal and the frontal sinus is coming like this, now what will happen? This will block the drainage of frontal sinus. Can you make it out? Okay, so this will block the drainage of frontal sinus. So we will call it as frontal cell. So the cells above the agar nasal, you see over here in this diagram, this will block the drainage pathway of the frontal sinus. So we call it as frontal cell. And there can be one frontal cell, there can be multiple frontal cells. Okay, so these are all the frontal cells which we will study further on. Right? So there can be one frontal cell, there can be multiple frontal cells. Okay, so this was about the ethmoidal air cells. We have seen a lot of ethmoidal air cells. But right now, all these ethmoidal air cells that I have talked about, you see the bulla ethmoidalis, the agar nasal, the suprabullar, the infraorbital or the halar cell, the frontal cells, these are all anterior ethmoidal air cells. Okay, all these air cells till now that I have taught you, all these air cells are which air cells? These are anterior ethmoidal air cells. Why? Because they all drain into the middle meatus. Okay, we have the posterior ethmoidal air cells. They drain into the superior meatus. Okay, in the posterior ethmoidal air cells, we have one air cell which is the most important, the utmost important posterior ethmoidal air cell, and that is known as Onodi cell. So we have talked about the anterior ethmoidal air cell. Okay, let's talk about the posterior ethmoidal air cell, and in that we have the Onodi cell. Okay, so first question about the Onodi cell, this is the posterior most ethmoidal air cell. So it belongs to posterior ethmoids, and the importance, it is posterior most ethmoidal air cell. Okay, now this cell lies in close proximity to sphenoid sinus. So of course we have behind the ethmoid, we have the sphenoid sinus. So this cell will lie in close proximity to sphenoid sinus. Okay, so it lies lateral to sphenoid sinus. So when it is present lateral to the sphenoid sinus. Okay, and you know it can go almost up to 1.5 centimeter laterally and behind the anterior wall of sphenoid sinus. Okay, anyways, we will discuss this cell when we will discuss the sphenoid sinus. Okay, before I go ahead, I just wanted to tell you one MCQ related to the Onodi cell. Onodi cell has optic nerve in it. Okay, so what is there in the optic nerve? In the Onodi cell, we have the optic nerve. Very easy to remember. Onodi starts with ON, so it has the optic nerve ON in it. Right, so whenever the Onodi cell is present, it's not present always, first of all. Okay, so whenever the Onodi cell is present, this cell has optic nerve in it, and because of that, sometimes there can be injury to optic nerve. Alright, so we'll discuss about it later when we'll discuss the Onodi cell. And remember, all these cells that I have taught you, they are not present always. Okay, these cells are not present always. These are variable cells. Variable cells means they may be present in one person, they may not be present in another person, or even they may be present on one side, they may not be present on the other side. So they vary from person to person, right? Somebody asks you which cell is almost always present, most consistent cell. So I have given you the answer for that. The most consistent cell is the bulla ethmoidalis. Right? So now let's look at some diagram. Let's see what all we can identify. Okay, so I hope all of you are able to identify in this diagram. This over here is the orbit, and below the orbit over here, this is the maxillary antrum. All right, I hope you are able to also see that this over here is the inferior turbinate and this is the middle turbinate, right? All right, okay, so what is this? This is a flap-like structure. I told you it is at the opening of maxillary antrum. We call it as uncinate process. Remember? What do we call it? We call it as uncinate process. Which bone? Okay, it belongs to ethmoid bone. Right? This uncinate process belongs to ethmoid bone. Right? And because of this uncinate process, we have over here a drainage pathway. This drainage pathway is known as infundibulum. Right? Okay, now what is this star marked air cell? Come on, most consistent cell of the ethmoids, that is your bulla ethmoidalis. Right? So this cell is your bulla ethmoidalis. Now the cell above the bulla is suprabullar cell, and you see the cell below the bulla over here, that is your infraorbital cell, also known as Heller cell. Okay? Right? So this is what we have just studied. So in another photograph, I have tried to enumerate all these things for you. You can clearly see the ethmoidal infundibulum between the bulla and uncinate. You can see this plane is known as hiatus seminularis. Right? Okay. Now let's go to the next over here. What is this? What is this diagram? This is a CT scan. Okay? Which contrast or non-contrast? It's a plain non-contrast. Okay, non-contrast CT scan of the nose and paranasal sinuses. Right? So we are going to study the non-contrast CT scan of nose and paranasal sinuses. Okay, and radiology is very easy. It's very simple. Once you have understood the anatomy, it's very easy, simple. Which cross section is this? So we have already studied this cross section. This is your coronal cross section. Which cross section? Coronal cross section. Right? So what do we see in this coronal cross section? Let's look at this side. You can identify the orbit, okay, and you can identify below the orbit we have the maxillary antrum. Okay, you can see that this is the inferior turbinate, we have the middle turbinate, just like the previous photograph. Okay, you can see I am putting a star mark over here, that is the bulla ethmoidalis. Above that we have the suprabullar cell, and below this we have the infraorbital or Heller cell. Okay, now I am putting my marks over here. That is, you see, the infundibulum. It has been made narrow because of the presence of Heller cell. Right? And this flap-like structure we know is the uncinate process. Right? Now let's go to the other side. Can we go to the other side? Yes, we can. We can see over here, this is the orbit. This over here is the maxillary antrum. Okay, what cell can we see over here? I am putting a star mark over here. That is your bulla ethmoidalis. Right? So the star mark cell is bulla ethmoidalis. Now above the bulla, you see above the bulla there is no suprabullar cell. You don't see suprabullar cell on this side. On this side you can see it was present. So you see these cells are variable cells. They may not be present. Okay, now let's look below the bulla. What do we see below the below? We can see over here there is a halar cell. And this halar cell, you see, it's a big halar cell. Okay, compare the halar cell. All right, let's compare the halar cell of the right side with the left side. So you see on the left side, the halar cell is much more bigger, right? So you see the halar cell is much more bigger. Now what happens because of the bigger halar cell? You see the drainage pathway of the maxillary sinus, it has become so much longer and tortuous. Okay, compared to this side, you can see that for the left side, the drainage pathway has become much more longer and tortuous. So that was over here the halar cell, right? Okay. So after discussing these interior ethmoidal air cells, let us now go and look at the frontal sinus. So you see, this is the frontal sinus. Now this frontal sinus is having an hourglass appearance, right? We have these frontal sinus above, and then there is a narrow frontal sinus ostium through which the secretions, you can see, they are coming out into the frontal recess. The frontal recess is the drainage pathway of the frontal sinus. And just like the maxillary sinus, okay, the ostium of frontal sinus is over here. And after that, the recess part is formed by the anterior ethmoidal air cells. So as you can see in the frontal sinus, we have the mucosa. The mucosa has the cilia, and the cilia beat and move the mucus. So you can see that these cilia are moving in this way. Okay, so they are rotating the secretions in this way. Okay, so you can see over here these secretions, they are going in a circular way. Okay, they start from here and they go all around, and they come out from the peripheral side. Okay, if there is a blockage over here, there is a partial blockage also, it will encourage more secretions going back. So a partial blockage of the frontal recess is also very significant. It doesn't require complete blockage. Even if there's a partial blockage, it will cause a lot of problem. So you see over here, this side also the same thing is there. From the central part, the secretions, they go up, then they rotate all around the frontal sinus, and then they come back from the peripheral side. If, however, there is a blockage, then it will go back. Okay, so this is the frontal sinus and its drainage system. Right? Okay, now let us look at the agar nasal. So remember, I have just taught you the agar nasal cell, and I told you agar nasal cell is the anterior most cell of ethmoids. Right? Let's identify the agar nasal cell over here in this diagram. So remember, the agar nasal cell lies in close proximity to the lacrimal cell. Okay, so lacrimal sac over here, you see over here, this is the lacrimal sac. This is the lacrimal sac for this thing, and the cell next to the lacrimal sac over here will be the agar nasal cell. All right, so in both the sides I have marked the agar nasal cell. It lies just next to the lacrimal sac. We know it is in close proximity to the lacrimal bone and the lacrimal sac. Now the cells above the agar nasal cell, I told you, are frontal cells. And I told you frontal cells can be one or they can be multiple. Now these frontal cells, we can classify them by a classification that's known as Kuhn's classification. Okay, so what is a Kuhn's classification? Kuhn's classification classify the frontal cells into 4 types. So what are the 4 types? Let's look over here. Type 1 frontal cell. What is type 1 frontal cell? Type 1 frontal cell is single cell above agar nasal. So on this side, on the right side, you can see that there is one single cell above the agar nasal. So this is known as type 1 frontal cell. Look on the other side. Look on the left side and you can see multiple cells above the agar nasal. So obviously they are causing more blockage in the frontal recess area. Then they are known as type 2 frontal cells. Okay, so type 1 frontal cell is single cell above agar nasal and type 2 frontal cell is multiple cells above agar nasal. Till now, these cells are in the frontal recess. I hope you understand the frontal recess. Frontal recess is this part which is below the frontal sinus ostium. Okay, now if these cells, they nematize and some part of the cell is in the frontal sinus. When we talked about these type 1 and type 2 frontal cells, we know that these cells are in the frontal recess. Okay, so as I showed you, the frontal recess is the part that is below the frontal sinus ostium. They have not gone in the frontal sinus. Now suppose these cells, they go in the frontal sinus, then these cells, the cell above the agar nasal, they are known as type 3 frontal cell. So type 3 frontal cell. So you see over here, this cell is going into the frontal sinus. Okay, this is known as type 3 frontal cell, and this special cell is not only in the frontal sinus, it is also above the orbit, so it is known as supraorbital cell. Okay, so as you can see in both the diagrams, we have supraorbital cells, and you can see because of that the secretions are accumulating in the frontal sinus. So we can very clearly see that there are secretions over here. They're blocking the frontal sinus much more significantly. Right? Okay, so this is a supraorbital cell or a type 3 frontal cell. Now, sometimes you see the frontal sinus cell, it totally loses touch with the ethmoidal air cells and is present as a single isolated cell in the frontal sinus. Okay, such a cell, as you can see over here, is loner cell, also known as satellite cell. Okay, so that is a type 4 frontal cell. Okay, it's literally it has no association to the anterethmoidal cells, so known as type 4 cell or loner cell or a satellite cell. Okay, lying in the frontal sinus. So this was the Kuhn's classification to classify anterior ethmoidal cells which are in relation to the frontal sinus and are known as frontal cells. Okay, so frontal cells are a part of anterior ethmoidal system. They are in close proximation to frontal sinus or its recess. They affect the drainage pathway of the frontal sinus. So therefore they are known as frontal cells. And we have classified them into 4 different types. Okay, this is known as Kuhn's classification. Type 1 is single cell above agar nasal. Type 2 is multiple cells above agar nasal. Type 3 is cell going into the frontal sinus, and type 4 is the loner or the satellite cell. All right. Okay. Now let's look at this question. So this question was asked in the AIMS June 2020 exam. Identify the structure marked as A in the given below image. Okay, so what is the structure over here? Now this is the lateral wall of the nose, and you can very clearly see they have over here drawn the inferior terminate. That's the middle terminate which they have cut, and they have shown a cell over here. This cell, you can see, this is the anterior most cell. Above this you can see the frontal sinus is draining, so this anterior most cell, it has to be agar nasal cell. Okay, so the anterior most cell of the ethmoidal system is the agar nasal cell. So clearly you can see that this cell over here is the agar nasal cell. So the answer to the question was agar nasal cell. Now before I go ahead, you see we have discussed these frontal cells, and these frontal cells we have discussed they are part of enteroethmoids, and we have discussed the Kuhn's classification. But there has been a recent update, and this update may be asked in your future INI CET exam. Okay, so they generally like to ask a lot of updates. All right, so it's a very important question for the INI CET exam, especially where they ask the recent updates and the changes in the nomenclature and all these things. So let us quickly revise what we have just studied, because there is a change in the name. Okay, so let's understand, because these questions are coming where a structure is marked and you're asked the type of the name of the structure or its type. So let's look over here. We just quickly will revise. Number one, we discuss the agar-nasal cell. So you can see over here, I have marked it with blue. We have the agar-nasal cell. This is the anterior most cell of the ethmoids, anterior ethmoids. Okay, and it will lie very close proximity to the lacrimal sac. Just next to lacrimal sac, the cell that we have is the agar-nasal cell. Okay, that's how we identify in the coronal cross section, and this is the sagittal cross section. Very clearly you can see the agar-nasal cell. So similar picture was asked in the AIMS exam, okay, June 2020, where you was asked the agar-nasal cell. Right, let's look at CT scan over here. In the CT scan, we have already discussed one CT scan for agar-nasal. Once again, you can see over here the lacrimal sac, that small bulge of the orbit on the medial side, and you can see the agar-nasal cell right next to this over here. Okay, in the sagittal cross section, you can see over here, this is the agar-nasal cell, anterior most cell of the ethmoidal system. Right, okay, now the cells above the agar-nasal, we call them as frontal cells. Now the new nomenclature is to call them as supra-agar cell. Yes, just like we call suprabular, so now this is known as supra-agar cell. Easy, very easy. Okay, so we have the supra-agar cell over here. You see, once again, there is the agar-nasal cell, and above the agar-nasal, we have the supra-agar cell. So over here also in the sagittal cross section, you can see that this is the supra-agar cell. All right, significance, you notice over here that there is a drainage pathway. This is the drainage pathway. It is going like this, hourglass drainage pathway, and both the agar cell and the supra-agar cell, they are on the anterior wall of this drainage pathway. All right, so they are over here. You see, they are over here on the anterior wall of this drainage pathway. Right, the agar cell and the supra-agar cell. Now you can see in this diagram, I'll show you the supra-agar cell. You remember, one cell above the agar-nasal, supra-agar cell. In the sagittal cross section also, you can see the supra-agar cell. Remember, the supra-agar cell can be one, it can be multiple. Right, so you can see over here we have the multiple supra-agar cell. So remember, these agar-nasal and the supra-agar cell, they are all in the anterior wall of the drainage pathway. So suppose this is the drainage pathway, they are in the anterior wall of the drainage pathway. Right, okay, now let's look in this CT scan. You can see over here in the CT scan, we have the agar-nasal, which we have marked with a star, with an asterisk, and you can see two supra-agar cell, 1 and 2 over here, 1 and 2 in the sagittal cross section also. So these are the supra-agar cells. Right, okay, if this supra-agar cell goes in the frontal sinus, now we call it as supra-agar frontal cell. Okay, so you see it has breached the frontal ostium and it has gone in the frontal sinus. So once again, if this is the drainage pathway of the frontal sinus, and we had one cell over here which we called as agar-nasal cell, now the supra-agar frontal cell has gone into the frontal sinus. Okay, so that is the supraagar frontal cell. So as you can see over here, it is going into the frontal sinus, right? Okay, now let's look in this image. You can see over here that this is the supraagar frontal cell. So you can see supraagar frontal cell. It is very anterior, right? Okay, now what we called as type 4 frontal cell, okay, or the loner cell or the satellite cell, is generally a variety of supraagar frontal cell which is now broken off, and you can see over here that this cell is lying lonely. Okay, it's a loner cell or a satellite cell. So you can see this cell is present. Okay, it is totally separate from the ethmoidal ear system. All right, so the name loner cell or satellite cell is still there, and this cell is there. Okay, now next we see over here the CT scan where you can see the type 4 frontal cell or the loner cell or the satellite cell, right? That is quite clearly visible. Now after understanding this, let's go back and look at this cell. What is this cell? Look in the second photograph, you will be quickly able to identify that this is the bulla ethmoidalis. Okay, so that's the bulla ethmoidalis cell. Remember, we talked about bulla ethmoidalis earlier in the diagram. Now I told you a cell that lies above this bulla ethmoidalis, above this most consistent cell, that is known as suprabullar cell. Okay, so this cell is known as suprabullar cell. So remember, now I was talking about the drainage pathway. So I told you that this drainage pathway has multiple cells. So there is a cell anterior to it, the anteriormost cell, agar nasi. There can be cell above the agar nasi. These are known as supraagar cell. Sometimes these cell may go into the frontal sinus. So we called as supraagar frontal cell. And this cell may separate out, okay, from the ethmoidal system, that is known as the loner cell or the satellite cell. Okay, now the drainage is over here. All right, anterior to the bulla ethmoidalis. So drainage is over here. Now any cell that lies above the bulla ethmoidalis, that is known as suprabullar cell. Okay, so you see now this suprabullar cell, it lies in the posterior wall of this drainage pathway. Okay, so this is known as suprabullar cell. It lies in the posterior wall of the drainage pathway, right? Okay, so that is the suprabullar cell. Now this suprabullar cell, we can have another cell, it may extend into the frontal sinus. Okay, so it may extend in the frontal sinus. So now it is known as suprabullar frontal cell. So once again, you see over here, we have the drainage pathway, okay, and we have the agar nasi, the supraagar cells, the agar, supraagar frontal cell, and we have the loner cell. Okay, and here we have the bulla ethmoidalis. We may have a suprabullar cell, and now I am telling you we may have a suprabullar frontal cell. Okay, so we may have a suprabullar frontal cell. So it is going in the frontal sinus, and obviously it will cause more blockage. Look in this photograph, in this CT scan. What do you see? Very particular CT scan that I've brought for you. You can see over here this star mark, that is the agar nasi cell, anteriormost cell. And above the agar nasi, you see the white arrow is showing the supraagar frontal cell. That's the supraagar frontal cell. And what do you see behind it? Behind it you see suprabullar frontal cell. Okay, so supraagar frontal cell, suprabullar frontal cell, and what do you see about the drainage pathway of this frontal sinus? You see this is the frontal sinus, and you can see that this drainage pathway has become such a long and narrow and tortuous drainage pathway. Okay, so that is the suprabullar frontal cell. right? Okay, this is the suprabular frontal cell. Now let's come to the frontal sinus surgery. So once we have understood these different kind of cells that can be present and they can block the frontal sinus in different ways, let's talk about the frontal sinus surgery. Okay, so there are different kind of frontal sinus surgeries that we can do. I'm just going to talk about few of them. The others we will talk about later. So first is the frontal sinus trephination. So this frontal sinus trephination, if you remember, we did a question in the last topic. There one choice was frontal sinus trephination. So I just wanted to tell you what is frontal sinus trephination. It is making an opening in the frontal sinus. So this is an external opening. Okay, it is made from outside, from the face, and generally you give over ear incision. This is an eyebrow incision. So when you give this incision, you have to take care of two nerves, the supratrochlear nerve on the medial side and the supraorbital nerve. In between you can give, there are different cosmetic incisions that you can give, all right, so as to open the frontal sinus. Right now, what is the advantage of opening this frontal sinus? Number one, you can use it simply to drain it, simply to flush it, to wash it. Sometimes you are doing surgery from inside, you're doing an endoscopic surgery from inside, okay, and you are not able to find the frontal sinus. I'm just giving you one example. Because of so many cells, you are confused, you are not able to find the frontal sinus opening. So what we can do is we can make a small opening, okay, very small opening, make a small hole and put in a needle. Okay, and with that you can put a dye inside the frontal sinus. You can see this dye coming out from the frontal recess. Okay, if there is a small, wherever is the opening, you'll see the dye coming out from there, and that way you can help you in locating the frontal sinus. You see the dye is being injected over here in the frontal sinus, right? And this dye, once injected, it will come out and you can locate over here wherever the dye is coming out. You can locate the whole pathway. So that is the first use of frontal sinus trephination, right? Other use that you can do is you can put an endoscope inside. You can make a little bit bigger opening. You can put an endoscope inside, and once you are drilling from below, it can help you identify the drill. Okay, so you can see your drill bit. It will help you for better drilling and opening the frontal sinus, okay, opening the ostium, giving it a better opening for the drainage. So you can put an endoscope inside and drill from below, or you can do it reverse. How can you do it reverse? You can put the endoscope from below and you can put your drill bit from above, from this external opening, and you can drill and make the frontal sinus wide. So that is another use for frontal sinus trephination. So the remaining frontal surgeries we'll study later. Let us now first go to the sphenoid bone. So we are studying the anatomy of the different paranasal sinuses. We have seen the anatomy of the maxillary sinus, the frontal sinus, the ethmoid sinuses. Let's come to the sphenoid sinus. So this sphenoid sinus is in the sphenoid bone, and we have already discussed a little bit of the sphenoid bone in the last topic in the video where I showed you all the different bones. Let us revise what we have studied. So we know that this sphenoid bone is in the shape of a bat. It's an unpaired bone right in the center. Okay, what are different parts of this sphenoid bone? In the center we have the body that is of course pneumatized to form the sphenoid sinus. It is divided in the center by the intersinus septum. So that part we have discussed. What else do we have? We have the greater wing of sphenoid, we have the lesser wing of sphenoid, and we have the pterygoid process. Okay, the pterygoid process has two plates, the lateral pterygoid plate and the medial pterygoid plate, as you can see in this diagram, right? Okay, now between the greater wing of the sphenoid and the lesser wing of the sphenoid, we have the superior orbital fissure. Remember, very important fissure, superior orbital fissure. Now this superior orbital fissure has important structures which pass through it. Okay, so they come from the cranial cavity into the orbital cavity, and we can divide this supraorbital fissure into three parts: the lateral part, the central part, which is in the annulus of Zinn, and then we have a very small inferior part. Okay, let's see what all structures they pass through it. We have the third, fourth, sixth, and fifth. Fifth, we have only V1, the ophthalmic division of the trigeminal nerve that comes through it. So these are the cranial nerves. I'll discuss a little bit more about supraorbital fissure later, but these are the cranial nerves that pass through it. We have a vein also, that is the superior ophthalmic vein, that also passes through the supraorbital fissure. Okay, now what other structure you can see over here? You can see over here one important structure over here. Now that important structure over here, see, that is the optic nerve. Okay, you can see the two sides optic nerve, they are going and they are fusing in the posteriorly, they are fusing over here to form the optic chiasm. So MCQ question, where is the optic nerve going through? It is going through the optic canal. Now where is the optic canal? The optic canal is in the lesser wing of sphenoid. I hope you remember, I have taught you this in the previous topic also. I told you the optic canal has three structures passing through it. Okay, remember, the optic canal has three structures passing through it. Number one, I told you, was the optic nerve. Number two, I told you, was the ophthalmic artery. So we have the ophthalmic artery, and number three, I told you, was the central vein of retina. So these three structures, they pass through this optic canal. Right? Okay, now the next question is, you see, this optic nerve is going through the lesser wing of sphenoid, but if you notice, it is forming an impression on the lateral wall of sphenoid. Posterior superior aspect, lateral wall, you can see the optic nerve. Okay, the cranial nerve 2, optic nerve, it is forming an impression. So this question is asked in the exam, which structures are visible in the lateral wall of sphenoid? So lateral wall of sphenoid, posterior superior aspect, number one structure you can see is the optic nerve. Now there is another bulge. Below the optic nerve, you can say there is another bulge, and if you see carefully, the other side is dissected and shown to you. You can see that this bulge is the bulge of ICA, internal carotid artery, which is going up. So the ICA is also there in the lateral wall, and it is forming the bulge. Okay, just lateral to that, we have the other nerves, the third, fourth, sixth, and the V1, but they don't have that much of an impression. Okay, we have mainly these two structures which almost always form an impression, a bulge on the lateral wall of the sphenoid. Okay, now what else do we have? We have over here the Vidian canal. That's also known as the pterygoid canal, and we can see that there is a nerve coming, that is the Vidian nerve. Okay, or the nerve of pterygoid canal. This nerve we have discussed in the ear, in the facial nerve topic, that this nerve is formed by the combining of GSPN, greater superficial petrosal nerve, and deep petrosal nerve. They together combine to form the Vidian nerve. So Vidian nerve comes from the middle cranial fossa and it crosses the Vidian canal, and thereafter it goes into the pterygopalatine fossa. Okay, so it goes into the pterygopalatine fossa, and from there it has four functions. I told you over there in the facial nerve topic that there are four functions. It supplies four places: the lacrimal gland, the nasal gland, minor salivary glands, and taste in palate. Okay, so remember, that is the Vidian nerve. Now above the Vidian canal, we have over here an opening that's known as foramen rotundum. Now this foramen rotundum, what passes through it? We have the maxillary nerve, that is the V2. Okay, so the cranial nerve V2, okay, second part of the trigeminal nerve, it comes out of the foramen rotundum. All right, so we can also see a foramen ovale. Only a small shadow is seen over here. It is below, so we cannot see it clearly. We know that the V3, the mandibular nerve, passes through the foramen ovale. So for ovale, you must know that there is a mnemonic known as male. Okay, so mandibular nerve, SS3 meningeal artery, lesser petrosal nerve, and MS3 vein. Okay, so once again I'll repeat: mandibular nerve, that is V3, then we have the SS3 meningeal artery, then we have the lesser petrosal nerve, and we have the MS3 vein. Okay, lesser petrosal nerve also we have talked previously. So these are the structures which are passing through the foramen ovale. Okay, right. So after looking at this image, let's go and look at this image. So what is this image? Now this is the image of the left orbit. So what can we see over here? In this image, you see, we can see the orbit, we can see the globe. The globe is shown as a transparent sphere, and we can see the extraocular muscles. So you can see the superior rectus, the lateral rectus, inferior rectus, and the medial rectus. You can see the full rectus, and then you can see the superior oblique and the inferior oblique muscles also. Okay, right. Now what I wanted to show you in this diagram is the superior orbital fissure. So you see, this is the superior orbital fissure, and this over here is the optic canal. All right, so you can see the optic canal, you can see the optic nerve coming out of it, and you can see the superior orbital fissure. Right, so let's see what structures are coming out of the superior orbital fissure. One structure, the first structure that you can see is the lacrimal nerve, that is a branch of V1. Okay, number 2, we can see the frontal nerve, again it is a branch of V1. Right, number 3, we can see over a muscle, a nerve coming out and going up to the superior oblique. So remember, we are always taught in the anatomy and in the ophthalmology SO4 LR6. So LR6 SO4. So superior oblique, we have supply from the 4th cranial nerve, that is the trochlear nerve. So you can see the trochlear nerve coming and rotating and going to the superior oblique muscle. So that is the trochlear nerve. What else we can see over here? We can see the superior ophthalmic vein. Okay, so now this part was the lateral part of the superior orbital fissure, which was lateral to the annulus of Zinn. Now we can see the central part. Above that we have the optic canal and the optic nerve. Now look, in the central part of the supraorbital fissure we have the oculomotor nerve, superior division. Okay, so that's the superior division of the oculomotor nerve. And then we can see the abducent nerve, the 6th nerve. Remember, the abducent nerve, 6th nerve, as I told you, LR6, it supplies the lateral rectus muscle. So you can see it is coming and supplying the lateral rectus muscle. Okay, the superior division of oculomotor, 3rd cranial nerve, has supplied the superior rectus muscle. And now comes out the inferior division of oculomotor nerve, which has gone and supplied the medial rectus and the inferior rectus muscles. Okay, and lastly we can see that there is a small nerve coming out, that is the nasociliary nerve. Again, this nasociliary nerve is a branch of the V1, the ophthalmic nerve. Right, okay, so that was the superior orbital fissure. We have not discussed the contents of the inferior part. The inferior part is very, very small. It is lying below the inferior rectus, and sometimes the inferior ophthalmic veins comes out of it. Okay, or if inferior ophthalmic vein can drain, it can go through the inferior orbital fissure also. Okay, so that is not consistent, the inferior ophthalmic vein draining, going out through the superior orbital fissure inferior part, or going through the inferior orbital fissure separately. right? So this was the superior orbital fissure and its anatomy. Okay, right? Now let us discuss a syndrome associated with this fissure. The syndrome is the superior orbital fissure syndrome, also known as Rochon-Duvignod syndrome. Now, this syndrome, usually the patient will present with ophthalmoplegia, ptosis, proptosis. The pupils may be fixed and dilated, and there can be decrease in lacrimation, lacrimal hyposecretion. There can be eyelid or forehead anesthesia, right? Okay, other than that, we can also have loss of corneal reflex. You see why we are having this? We are having these because of involvement of cranial nerve 3rd, 4th, 6th and V1, right? Okay, now this superior orbital fissure, the most common cause that is trauma. That is generally the cause. Now in this supraorbital fissure, okay, you see the trauma is the cause. The cranial nerve 2, however, is spared. If you go back over here in this photograph, you will see that the cranial nerve 2 is spared. Why it is spared? It is spared because this involves this part. Okay, so there is a bony chip. Generally after the trauma, the bony chip impinges on the nerves and can cause the superior orbital fissure syndrome. Okay, now orbital apex syndrome. Now we have to differentiate the orbital apex syndrome from the superior orbital fissure syndrome. So orbital apex syndrome, also known as Jacquard syndrome, the main differentiator is the involvement of optic nerve. So the patient will have blindness. And this orbital apex syndrome, okay, it is generally because of inflammatory lesions. It can be because of infectious lesions. It can also be because of tumors. Okay, so generally these are the problems that can cause the orbital apex syndrome. Tumor and all, they can initially involve the supraorbital fissure, but later on they will go and involve the optic nerve, and that is why this is known as orbital apex syndrome. Look over here, this is a infectious lesion of the sphenoid sinus. So you see, this is an infectious lesion of the sphenoid sinus, and from there it has gone and it has involved over here the orbital apex. So when I say the apex, the whole part is involved. Okay, so if the superior orbital fissure syndrome, all the symptoms will signs will be there, including the blindness, which is because of involvement of optic nerve and the optic canal. Okay, so you can see this is the orbital apex syndrome. Okay, now let's look at the sphenoid sinus CT scan. So this is the coronal view of the sphenoid sinus. What can you see over here? You can see the sphenoid sinus over here. This is the right sphenoid sinus. This is the left sphenoid sinus. Okay, now what else can you see over here? You can see a boundary, that is the, this is the greater wing. We can see this little bit of the lesser wing over here also. In between them you can see that this is the superior orbital fissure, right? So you can identify the superior orbital fissure also over here. This is the optic canal, and you can see the optic nerve. Optic nerve over here has been marked as number 2, right? Okay, what else can you see? You can see over here, this is the pterygoid process. So we have the medial pterygoid plate and the lateral pterygoid plate also, right? Where the pterygoid process, the base is there. We have at the base a canal. That canal is known as Vidian canal. So on both the sides you can identify the Vidian canal. Okay, above the Vidian canal there is a small opening, and this small opening over here is known as foramen rotundum. Right, so all that we have studied in anatomy we can see in the CT scan also. Okay, so remember, the optic nerve lies in the lateral wall of the sphenoid sinus. Okay, so this was the coronal view. Let's look at the axial view. So when we look at the axial view, you can see that this is over here the posterior most sinus, this over here, this is the sphenoid sinus, and you can see the eyeball over here, that's the eyeball, and you can see the optic nerve will come out of here, and it goes through the optic canal lateral to the sphenoid sinus. Okay, so it is in the lateral wall of the sphenoid sinus, in the posterior superior aspect it goes, right? Okay, so this is the CT scan of the sphenoid sinus. Now let us talk about Onodi cell. We have talked a little bit about the Onodi cell earlier. I told you I'll show you and I'll explain you later. So we know Onodi cell, this is the posterior most cell of ethmoid. Okay, posterior most cell of ethmoid. I told you it lies in close proximity to sphenoid sinus. Okay, so this is the sphenoid sinus. This is the sphenoid sinus, and the Onodi cell lies lateral to sphenoid sinus. Okay, so you can see that this over here is the Onodi cell. Now I just explained you what is lateral to sphenoid sinus, what is there in the lateral wall. In the lateral wall we have the optic nerve. All right, so now if this Onodi cell is present lateral to the sphenoid sinus, so what will it have in it? It will have, of course, the optic nerve. So as you can see over here, we have the optic nerve. Okay, so the optic nerve is present in the Onodi cell, right? Okay, now what is the significance of this statement? The significance of this statement is that suppose there is a surgeon and who wants to operate on the sphenoid sinus. So he's gone endoscopically, he's put his endoscope inside. So let me show over here, he's put his endoscope inside in the nose and he's trying to go into the sphenoid sinus. So what will he do? He will encounter the anterior ethmoids, he will break them, he will go straight, he will identify the posterior ethmoids, he will break these posterior ethmoids, and if he tries to go straight like this, if he keeps on going straight like this, now what will happen? He will damage the sphenoid. Okay, so what is the significance of the Onodi cell? What is the significance? Now let's go back over here. Let's look at this axial cross section of the sphenoid sinus. Now suppose there is a surgeon and he wants to operate on the sphenoid sinus. So what can he do? He'll put his endoscope inside, okay, his instrument inside, he will identify the anterior ethmoids, he will break them, he will go into the posterior ethmoids. And then he will identify them, he will break these posterior ethmoids, and you can see straight it goes in the sphenoid sinus. Right? Okay, so that is clear to you. That is how you can read the sphenoid sinus. However, suppose we have a Onodi cell. Now we have a Onodi cell. So what has happened? When you have a Onodi cell, you go inside and the surgeon tries to repeat the same thing and he tries to break the anterior ethmoid. He will enter into posterior ethmoid, and if he keeps on going straight and he tries to break the posterior ethmoid, he will damage the optic nerve. Okay, let's look at the CT scan over here. Now this is the CT scan and you can see over here that this is the sphenoid sinus and the yellow marked structure over here, that is the Onodi cell. So if you try to go straight like this, okay, so you will break these cells and you will not go in the sphenoid sinus, rather you will damage the optic nerve and patient will have blindness. So it is very important that if the Onodi cell is present, it has to be identified on the CT scan, so that when the patient comes operating like this, so it is very important to identify the Onodi cell in the CT scan. Why? Because when the surgeon comes operating on a patient and he goes straight like this, you know, he knows that after some time when he will reach into the posterior ethmoids, he cannot go straight, he has to change his direction medially so as to enter into the sphenoid sinus. Okay, if he keeps on going straight, he will end up damaging the optic nerve and giving blindness to the patient. So Onodi cell is the posterior most cell of ethmoid. It lies lateral to the sphenoid sinus, and it has optic nerve in it, and that is the significance that because the optic nerve is in the onodicell, it is prone for damage, right? So this is prone for damage, right? This is the coronal cross section of the sphenoid sinus. So you can see the two-side sphenoid sinus, and you can see that there is the onodicell over here, which is lying between the sphenoid sinus and the optic nerve. So you can see the optic nerve, instead of lying in the sphenoid sinus, is now in the onodicell, right? So it is now lying in the onodicell. Now this question was asked in the JIPMER May 2018 exam, optic nerve injury following sinus surgery. Okay, so they have clearly mentioned that there is an optic nerve injury and patient has undergone sinus surgery is due to removal of which ethmoidal cells. So we know which ethmoidal cell. Answer is of course onodicell, right? Okay, so which ethmoidal cell? Onodicell. Okay, if onodicell was not mentioned and they have not asked ethmoidal cell, which sinus they would have said, then we would have marked answer sphenoid sinus, but they have specified ethmoidal cell and the answer is onodicell. Okay, right, now let's come to the sphenoid sinus nematization. Now we have seen the sphenoid sinus, we know the sinus is in the sphenoid body, but the amount of air, nematization means the air, the amount of air in this sphenoid sinus may vary. It can be less, it can be more. Okay, so sphenoid sinus, if the amount of air inside the body is very less, it is known as conchal nematization. Okay, this type of nematization, as you can see over here, little bit amount of air, this is known as conchal nematization. Now, what is this over here? We have discussed in the sphenoid, this is the sella turcica. Okay, so this over here is the sella turcica, right? Now, if this nematization reaches till the anterior wall of sella, you can see in the second diagram, it has reached almost the anterior wall of sella. This is therefore known as pre-sellar nematization. You see, I have drawn the line anterior wall of sella, so pre-sellar nematization. And if this nematization reaches all across the floor till the posterior wall like this, then this is known as sellar nematization. Sellar nematization is the most common nematization seen in approximately 54% cases. Okay, second most common is the mixed nematization seen in approximately 27%, where one side may be sellar, other side may be pre-sellar or conchal, like that. Okay, right, and conchal nematization is the least common, seen in 1 to 4% cases. So conchal nematization is the least common type of nematization. Now, what is the significance of this nematization? Why are we talking about this nematization? We're talking about this nematization because in today's era of endoscopic surgeries, we can do the pituitary surgery by the endoscopic approach through the nose. Okay, so we know that the pituitary gland, the hypophysis that is there in the sella turcica, which lies above the sphenoid sinus. Right, okay, and if there is a pituitary tumor, you can do the surgery instead of opening the brain, the cranial cavity, you can do the surgery by putting an endoscope from the nose, reaching the sphenoid sinus, breaking this bone and going into the pituitary gland. You can take out the tumor from this way. It's quicker, it is safer, it has less complications. But you have to understand this thing, that this nematization plays a big role in the surgery. How? Suppose there is a sellar nematization. Now sellar is the most common nematization, so you will find a thin plate of bone between the sphenoid sinus and the pituitary gland. This you can easily break and you can reach into the middle cranial fossa and you can take out the pituitary tumor. Okay, however, if you get a conchal pneumatization, now you can see that the amount of bone is much more. Now this bone cannot be removed, it has to be drilled away. So you have to use a drill. So you will need special instrument. Okay, you have a special drill that can be put from the nose. You can reach with this drill to the sphenoid bone and you can drill the bone. Okay, so you need a long nasal drill to drill the bone, so it will take more time. You need to have an experience of drilling the bone under an endoscopic vision. Then you see that on the two sides of this body we have the optic nerve. We also have the internal carotid artery which is going up. So you are drilling in between the vital structures. You have to be very careful while drilling. Your drill should not touch any of these structures. If you damage the optic nerve, you will have blindness. If you damage the ICA, patient can die on the table. So the complication is more, instrument requirement is more, time taken is more, experience required is more. Okay, so all this will depend upon what kind of pneumatization is there, whether it is a cellular pneumatization or it is a conchal pneumatization, and therefore we need to understand this sphenoid pneumatization. And that is why pituitary tumor, you may do a MRI to identify the tumor, but you also have to do a CT scan to see the bony structure and your approach to the endoscopic surgery. Right? Okay, so that was the importance of sphenoid pneumatization. Now, since we have been discussing about the sphenoid pneumatization and the pituitary surgery, let us also discuss the superior relation of the sphenoid sinus. Okay, so what do we have superior to the sphenoid sinus? This is the sphenoid sinus, you can see in the photograph. Superior to it, we have the hypophysis, the pituitary gland. Now, what lies lateral to the pituitary? We have the cavernous sinus. You can see superior to the sphenoid sinus, we over here have the cavernous sinus on the two sides. Okay, now what all structures you can see inside the cavernous sinus? You can see inside the cavernous sinus that we have the ICA, the internal carotid artery. So it is passing through the cavernous sinus along with the sympathetic plexus around it. Right? Okay, what else do we have? Near the ICA you can see the cranial nerve 6. The sixth cranial nerve and the ICA both are passing through the cavernous sinus. Okay, and then other than that we have a few nerves in the walls of the cavernous sinus. Now, which are those? We have the third cranial nerve, the oculomotor, we have the trochlear, fourth cranial nerve, we have the V1, the ophthalmic division of trigeminal, and we have the V2, the maxillary division of the trigeminal. Okay, so they are in the walls of the cavernous sinus. Okay, now remember, cavernous sinus is just like any other dural venous sinus. So we discussed the dural venous sinus in the ear topic. Okay, so just like any other dural venous sinus, we have the cavernous sinus, but it is different in some aspects. So how is the cavernous sinus different or similar to dural venous sinus? You see, just like the dural venous sinus, it is lined by the epithelium. It is formed between the layers of the dura. Okay, it is carrying the venous blood. But the differentiating point is, number one, you can see that in this cavernous sinus there are lot of trabeculae, so which are not seen in the other dural venous sinus. So it's a unique sinus, there are a lot of trabeculae. Then this is the only sinus through which an artery and nerve are going through. You see, the artery, the ICA, and the nerve, the sixth nerve, they pass through the cavernous sinus. Okay, so this is the only venous sinus, dural venous sinus, in which we have the trabeculae and the artery and the nerve going through the sinus. Okay, now this cavernous sinus is very important for ENT because a lot of diseases can spread, especially the infectious diseases, and sometimes the tumor of the nasal cavity can spread to the cavernous sinus. Okay, so the infectious diseases such as in the frontal sinus or in the sphenoid sinus or the ethmoid sinus, so these infections, when they spread, they can cause cavernous sinus thrombosis. If you remember, we have discussed about a cavernous sinus thrombosis in the external nose also. We have the danger area of face. From here also the infection can quickly go to the cavernous sinus and can cause cavernous sinus thrombosis. Okay, now the cavernous sinus thrombosis has become extremely rare now, and that's because of development of a lot of antibiotics which were not there earlier. So how will a patient of cavernous sinus thrombosis present to us? Patient will have fever, of course. So number one, patient will have fever, patient will have headache. Okay, so patient will have a severe headache, patient will have fever, patient will have periorbital edema. So he'll come with these complaints. There is a swelling around the eye, there is fever, there is headache. So he'll come to this with these complaints to us. Now what do we find on examination? On examination, you will generally see that there is a lot of periorbital edema in the patient. Okay, there can be chemosis that you can see over here, and then there can be engorgement of the veins, the caput medusae. This is known as caput medusae. This is engorgement of the veins. And remember, there can be lateral rectus palsy. Okay, why? The sixth cranial nerve is going through the cavernous sinus. So cranial nerve 6 is the first cranial nerve that will be affected in the cavernous sinus thrombosis. Right? Okay, let's look in this image. In the MRI over here, you can see that the left side cavernous sinus, it has enlarged, okay, and it is inflamed. So we have a cavernous sinus thrombosis over here. Right? Okay, remember the ocular manifestations of cavernous sinus thrombosis, they can reflect the disease, they can reflect what structure is involved. So suppose there is a ptosis, that's because of involvement of either the third oculomotor cranial nerve, or it can be because of the sympathetic plexus that is around the ICA, or it can be simply because of the edema of the upper lid. Okay, so any of that can be the leading to ptosis. Then the patient has chemosis. The chemosis is because of the thrombosis of superior and inferior ophthalmic vein, which are not able to drain away the blood. Then patient can have proptosis, that is also because of the venous engorgement that is pushing the eyeball out. Then patient can have loss, sensory loss. There can be periorbital pain, that is because of involvement of fifth trigeminal cranial nerve. The lateral rectus palsy, I told you, is because of involvement of the sixth cranial nerve, and the sixth cranial nerve is the earliest cranial nerve to be involved. Okay, and then patient can also have ophthalmoplegia. We know the ophthalmoplegia can be an internal ophthalmoplegia, it can be a total ophthalmoplegia because of involvement of third, fourth, sixth cranial nerves. Okay, now remember, how will you differentiate the cavernous sinus thrombosis from orbital apex syndrome? Okay, how will you differentiate? See, I told you the superior ophthalmic fissure syndrome and the orbital apex syndrome. I told you in the orbital apex syndrome, the cranial nerve 2 is involved. So there will be blindness. Okay, right? Now, the blindness is not seen in superior orbital fissure syndrome. So when there is a cavernous sinus thrombosis also, you will not see blindness. Okay, so blindness is not there in cavernous sinus thrombosis also. It is not there in the early disease. So how will you differentiate these from the other two syndromes? Now remember, number one thing, there is sympathetic chain involvement. Okay, around the IC there is sympathetic chain involvement. Patient will have Horner syndrome. So you see, there is Horner syndrome, so patient will have ptosis, meiosis, anhydrosis, loss of ciliary function. So that will be there in cavernous sinus thrombosis. Okay, so that is how you can differentiate the cavernous sinus thrombosis from the superior orbital fissure syndrome. And the orbital apex syndrome will of course have the blindness, which will differentiate it from the other two syndromes, right? Okay, the treatment for cavernous sinus thrombosis is high dose of IV antibiotics, and generally nowadays we have very good antibiotics, so we can save a lot of patients. Otherwise earlier we used to lose almost all the patients. Okay, right. Now before we end this topic of the paranasal sinuses anatomy, previous topic we have studied the nasal anatomy. Now let us finish this topic by watching a video on the diagnostic nasal endoscopy. So diagnostic nasal endoscopy consists of the three passes: the first pass, the second pass, and the third pass. Okay, so let's see each of these passes, first, second, and third. Let us first start with the first pass. So what do we see in the first pass? We put an endoscope. Okay, with this you can see over here, this endoscope is going, it has been put inside the nasal cavity. So this is the patient's left nasal cavity. You have put the scope inside, and you can see over here that this place over here, this is the nasal septum, this is the inferior turbinate. Okay, so we will go straight in the left nasal cavity. So we'll go straight along the floor and we will go into the nasopharynx. Okay, so this is the septum, this is the inferior turbinate, and we are going straight into the nasopharynx. Okay, so you can see the nasal septal deviations in it, you can see the inferior turbinate, the floor, and now we have come into the nasopharynx. So what do we see in the nasopharynx? You can see over here the eustachian tube openings of the two sides. We'll be studying about them in the nasopharynx. You can see behind these two eustachian tube openings, posterior superior to that, there is a space over here. That space over here is known as fossa of Rosenmuller. So I'm taking my endoscope deep inside so that we can have a better look at the fossa of Rosenmuller. You can rotate the scope. Okay, so I'm rotating the scope, or you can use an angled scope to look at inside this more clearly. Okay, so now we will bring our endoscope back. Okay, now while bringing the endoscope back, you can see we are again bringing it along the floor. This is the inferior turbinate, and you can rotate the scope below the inferior turbinate into the inferior meatus. Okay, so you can see over here I've rotated the scope into the inferior meatus, and you can have an opening over here. You can see this opening. So remember which opening is there in the inferior meatus? Yes, that is the opening of nasolacrimal duct. Okay, so you can confirm by doing eye syringing. Okay, so when you do syringing, or you can press the lacrimal sac over here, the lacrimal fossa, and you can see the tears coming out. See, you press the lacrimal sac, so whatever tear is there, that will come out from the lacrimal sac. Okay, so that is the nasolacrimal duct opening. So that, my friends, was the first pass. Okay, you go along the floor between the inferior turbinate and septum, and you go straight into the nasopharynx. Now let's come to the second pass. Okay, now for doing the second pass, we'll take the endoscope straight once again, just like we did earlier in the first pass. But instead of going in the nasopharynx, when we see the posterior choana, we go 1 to 1.5 centimeter above it, medial to all the turbinates, and we can see over here the sphenoid sinus. Okay, so that you see is the sphenoid sinus, and this structure over here which is shining white, that is the superior turbinate. Okay, so remember the sphenoid sinus is over here between the superior turbinate and the septum. This place over here is known as sphenoethmoidal recess above the superior turbinate. Okay, so right on the lateral wall above the superior turbinate we have sphenoethmoidal recess, and now we are coming back. You can see the sphenoid sinus ostium, that is the superior turbinate. This is the septum, this is the middle turbinate. Okay, so the second pass we see the sphenoid sinus ostium. right? Okay, so now let's come to the third part. Now in the third pass, what we will do is we will take our endoscope and we will try to go into the middle meatus area. So you see, this is the middle turbinate. Okay, so what we can see over here, this is the middle turbinate. Now this structure which is a boomerang shaped structure, this is the uncinate process. And once we go across them, over here you can see this cell, that is the bulla ethmoidalis. Okay, right? So we can see, I'm pointing out once again to you, this is the uncinate process. It is a boomerang shaped structure, that is the uncinate process. Okay, and that has a vertical part, a horizontal part, a small over here medial or the intermediate part. Now I am showing over here the bulla ethmoidalis. Remember, between the bulla and the uncinate process, we have a plane that is known as hiatus seminaris. So you see, this is the hiatus seminaris. I go through the hiatus seminaris into the space that is known as ethmoidal infundibulum. So I have put my probe into the hiatus seminaris. Okay, and once I have crossed the hiatus, I have gone to the infundibulum, and the infundibulum will lead me over here into the maxillary sinus. Okay, so that is the maxillary sinus opening. This is the middle turbinate. Okay, so this is the middle turbinate which is being shown to you. All right, now this third pass we can do another way. The first was going directly. The other way is you go straight, just like you went in the first pass. You go straight and then you rotate your endoscope below the middle turbinate and you come in the middle meatus, and then while withdrawing the endoscope you can see these structures. Okay, so I'll repeat it for you, that while withdrawing the endoscope we are able to see the middle turbinate, then we can see the bulla, and after the bulla comes over here the uncinate process, and we can come back looking at these structures. Right? Okay, so this was the diagnostic nasal endoscopy, the three passes that are done. Right? Okay, this question was asked in the INI CET November 2020 exam. Identify the structure marked in the following endoscopic image of nasal cavity. So you can see that the endoscope is right at the entrance of the nasal cavity. You can see this is the nasal septum, this is the right nasal cavity. How I can say that? Because I can see that these turbinates are coming from the side, they are on the lateral wall. So you see this is the right nasal wall and this is the septum. So this is, we are right at the first pass. Okay, you can see the endoscope is at the floor. This is the lowermost turbinate. You can see the anterior end of this turbinate, the lowermost turbinate. So therefore this is the inferior turbinate. Behind that I can see the middle turbinate. If I go a little ahead, okay, and I can probably see the superior turbinate also. So this was a pretty simple question. The answer to this was inferior turbinate. Okay, so that was the anatomy of the paranasal sinuses. I've tried to explain all the different cells to you. I hope they are now clear to you. So then we'll go to the next topic. Okay.